Hi, I'm Rachel Kelly, and I'm completing the entry level of Master's in Nursing program at Pacific Lutheran University. So for my capstone project, I worked with the ambulatory leadership staff at Mary Bridge Children's Health Center, which is located in Tacoma, Washington. So for the focus of my project, it was on reducing the no-show rate at a pediatric outpatient clinic through the development of a predictor model. My preceptors were Cami Herkimer, the Associate Chief Nurse Executive and Ambulatory Administrator, Medical and Surgical Specialty Practice, and Jamie Eckhart, who is the Nurse Manager of Ambulatory Operations. So first, I'm going to talk about some background information on the topic of no-shows. So for outpatient clinics, no-show appointments can be defined as patients who fail to present for a scheduled appointment without contacting the clinic to cancel the appointment with at least 24 hours in advance. No-shows can greatly affect the healthcare delivery service and overall patient outcomes in that it results in decreased efficiency, higher use of resources, longer wait times, practice discontinuity, worse health outcomes, and lower patient satisfaction, especially for patients who are experiencing chronic illnesses. In the pediatric outpatient setting, where this project was modeled and implemented, the no-show baseline rate was found to be 10%, which accounted for around 10 to 9 no-shows a day. This was obviously cause for concern in that practitioners were becoming dissatisfied, revenue was being affected, scheduling and operational difficulties arose from it, productivity was diminishing, and care management for patients was being affected. So for this project, my PCOT question was to ask if factors found from a predictor model in comparison to prior appointment scheduling techniques used in the previous baseline year will reduce the number of annual no-show rates. And so my objective for this project was to identify the likelihood of a patient no-showing their appointment through the creation of a predictor model and to test the performance of the model on subsequent patient visits through tailored interventions. I conducted a comprehensive literature review and found that prediction models have been found to be successful in reducing the no-show rate in prior studies, and that is why I chose it as a best practice for this quality improvement project. So the data for this project was obtained by my analytics software program, which was provided to me by the hospital, and the data was filtered to pertain to only the pediatric neurology clinic in which I tested it. The data included information from the total number of completed appointments and the number of no-show appointments from the year 2019. The testing set included around 20,000 total patient records. Logistic regression was conducted using data analytical software, which is known as Python, in order to anticipate the likelihood of patients who would no-show or cancel their appointments with less than 24-hour notice. I used 5 independent variables, which were patient age, payer information being insurance, patient zip code, provider, and days waiting from time of appointment being scheduled to when the appointment was either completed or canceled. The outcome that was being measured was whether certain characteristics are predictors for a patient no-showing or showing up to their appointment, and evaluation was based on the percentage found to be accurate regarding predictability of patients no-showing. So prior to the Quality Improvement Initiative, appointment scheduling usually consisted of calling patients 2 days before their scheduled appointment and the day before the patient was still unconfirmed. And many of these calls were turning into cold calls in that they went straight to voicemail. Paper letters were also being sent out and were often returned to the center. So the front office staff, who were the ones making the calls, sending out the letters, were saying that the process was very labor intensive. So based on the results that I found from my predictor model, I was going to have interventions that were going to be targeted to these high-risk patients. My interventions were going to be tailored to the characteristics that were to be measured through monthly auditing and based on the number of no-shows the clinic had at the end of each month. And then the total no-show numbers by the end of the trial year 2020 would have been the final measure to see if the desired outcome of reducing the no-show rate from 10% down to at least 5% was met. So for the actual predictor model, it was trained on 80% of the data that I gathered. 20% was found to be unnecessary and therefore it was hidden from the model. The logistic regression analysis looked at what is known as the receiver operating characteristic, which tests for what percentage would be caught to no-show and what would be missed. And it determined there would be around a 60% true positive rate, which is represented in the y-axis. I don't know, it might be a little hard to see on my poster, but it's the graph that I posted under figure 1. And that's what's representing the y and the x-axis, the red and the blue line. So the y-axis is showing that it would accurately catch those who would no-show. And then represented in the x-axis is showing what the false positive rate would be, and that came out to be around 30 to 40%. And this represents wrongly catching a no-show. So in the end, this was concluded to actually not be a strong model, since this wasn't an ideal outcome, which would be to have the true positive rate around 80% or higher and the false positive rate under 10%. So I did find some characteristics, though, that correlated with having a high risk for no-showing, and this was found by finding the mean of each individual variable. The age encounter was put into an age range, and the highest mean was found to be 0.45%, which represented the age of 18. A certain provider, which for personal identity reasons cannot be named, had a mean of around 78%. Zip code had a 71% percentage, and payer information was 27%. And the payer information was Cigna Health Insurance. But for personal identity reasons, I can't say the zip code. But I did find also the average day waiting was found to be 7 months with a mean of 33%. So a classification point of 0.5, representing 50%, was set in order to minimize total errors. So any variables that scored around or under 0.5 was determined to be because of weak predictors. Anything above that would be considered a strong predictor. The only variables having 0.5 or higher were the provider and the zip code, so those were considered to be strong predictors. The interventions were beginning to be tested by the front office staff at the neurology clinic, and these were targeted to the high-risk patients founded by the Predictor model, and it included emphasizing an online appointment scheduling tool known as MyChart, working closer with the referral system, and scheduling waitlisted patients. But unfortunately, due to COVID-19, it caused many in-office appointments to be canceled or shifted to virtual visits only, unless under certain circumstances. And this was not considered when the creation of the model and interventions were put in place, so therefore measuring the interventions would be inaccurate. So I didn't include those in the outcome. But in conclusion, creating a model that predicts patient or provider behavior has been a relatively new idea for those in the healthcare field interested in improving patient access to care. And so my hope for this project was to have results consistent with past research that showed predictive modeling could be used in a clinic to predict a patient's future no-show behavior and use it to tailor interventions that were successful in reducing the no-show rate. But there were a lot of limitations for this project, which included lack of consistent information between completed appointments and the non-completed, which lessened the accuracy of my outcomes. And a stronger model would have consisted of more independent variables, but the data I had was so limited. And also time restriction was also an issue because of COVID-19. It changed a lot of the in-office appointment scheduling tactics. But my results did show that a predictor model can be used on outpatient clinic data, and certain correlations can be found in patient behavior. So my recommendations for future studies would be to have a broader set of data that includes more patient factors such as history of attendance and reason for cancellation. And I would say having variables of 20 or more would also have really helped with this predictability model, because I think 20 or more has been shown to conclude with stronger results and predictability. So that would be beneficial. Also, having more time for testing. The goal for the study was originally supposed to measure the outcomes on a 6-month to a year basis, not under 3 months, which is what happened because of COVID-19. In the end, though, I think more quality improvement initiatives focused on improving outpatient care through technology should be considered. I think technology is proving in other research studies to be an efficient and effective tool to improve healthcare outcomes. So in the end, lessons learned. Not everything is going to go the way you want it to. Time just wasn't on my side with this. And I was really hoping to come up with a stronger predictor model, but it was my first time doing it, so I'm not going to beat myself up over it. But I really do want to work with quality improvement initiatives in the future with technology, because I think technology is really going to change the future of healthcare. So this is the end of my presentation, and I just want to thank you for listening. And again, I want to thank the leadership team at Marybridge Health Center for mentoring and guiding me throughout this project. If you have any questions about this presentation, please feel free to reach out to me. Thank you so much.